everyone. Welcome back to another episode of ResearchWorks podcast. I feel like I need to say that in a slightly different way each time, but I don't really. We've done quite a few of these episodes now. We're here at EACD Galway, Ireland 2026, and it's the final day, so it's a little bit quiet around the place, but it's a good day for a good conversation. And when you want a good conversation, you've got to pull up a friend and say, hey, let's just chat. There's no agenda. Hello, Brian Hall. Welcome.
Hi, Dana. Thanks for inviting me back.
I like it. When I contacted you about this, the whole idea of it was, let's just have a chat about what we've learned from conference, reflections, thoughts, what does this mean? Because you and I are both very practical people. We come to these, we learn, and then we go and do. And we do in real world context, right? We appreciate research, of course, and why good studies need to be done. But that piece of translating research into actual everyday practice, considering the context, which is funding, real life, it's messy. How do you do that? Like, as a big question, you come to these, you get these ideas. How do you then sort of think about putting this into practice? You do that very, very well. I mean, you're part of generating knowledge as well.
It's a big question. I mean, I think just taking you up on that first introduction about sort of who we are and our backgrounds and where we are, I think I would have to say we're in a bubble. And I think I'm sure you would agree with that. And I think the sort of whole theme of the F words in this conference, it means a lot to us. And I think we have considered that for a long time.
That's right.
And I think implemented it in our practice. So for me, it's sort of, I think the way of thinking around these 6 Fs has been a way of thinking for most of my career, thankfully. But I think Peter and Jan Willem have done an amazing job of really sort of defining what they are and coming up with these terms that really have meaning. So to me, I think it's absorbing information. It's questioning information that, and it's just really taking, I think, if you can get some golden nuggets that you can take home from every conference, that's what I come here for.
That's right.
To implement in practice. But I think I think we've had a brief discussion over the last few days around what happens outside the bubble. Those clinicians who are working really hard on the ground, slogging it out, who don't necessarily have the opportunity to come to forums like this to hear the consistent messaging and where do they go to get the messaging. It's probably led a lot by algorithms and where that I think I would like to talk to you a little bit about that conundrum.
I think it's a really important one because, I mean, it's something certainly that has struck me because, we've talked about the F words endlessly through the podcast. It's framed a lot of our thinking for a long, long time. And when you hear everyone's for it, we are preaching to the converted here. It is the F words. Everyone's like, yes, it is, right? Yes. And my thinking is, all right, well, how do we get this out of here and into the real world, Yeah,
and I don't think there's an easy answer. I don't think that there's a single concept or aspect that's going to lead to that. But I was actually just having a chat to a very interesting OT student who's also a mother of she's doing OT because she's got a 4-year-old child, GMFCS4 CP.
We've had her on the pod. I think I know who you're talking about. Yes. Hello, Deborah.
Hi, Deborah.
I'm sure you're listening.
I was keeping you anonymous, Deborah. But I think I asked this question around sort of the journey that she's been on and culturally there's differences, and I think it gets back, and Peter mentioned about the biopsychosocial model of disability and how I think in many countries that's been embedded as part of their way of thinking with disability for a really long time, in parts of Europe, etc.
That's right.
Where culturally there are vast differences. In Australia, I think the difficulty is even just that at that fundamental level of how disability is viewed. I think the NDIS has done in terms of obviously there's
some challenges.
the challenges, but what it has meant is just much more visibility around disability. So I think that's a fundamental, important first step.
Yes.
then I think from that, and what Deborah was saying was around just where that it really resonated with her when her clinicians and team around her was just saying, see the child, don't see the sort of disability or the condition, and really try and support the person.
Yes.
And I know that sounds straightforward and perhaps rather simplistic, but that for her was what she said she felt made the biggest difference, and moving away just from focusing purely on one of the F words being function, which I think is what dominates.
Sure, of course.
And that sort of, and I think function's an interesting one at how that's viewed.
Yes.
I think I'll let you talk, but I think that's also a discussion as well about when you talk about function, it can mean many things to different people.
It can. And I think there's, on that, and maybe that's what you're alluding to as well, it can be misappropriated very easily, very, very quickly, because functioning, I think, is a great entry point to start, because I think there is also a process. We spoke about this briefly yesterday. You know, there's a process. You know, you speak to many, many families, and there's a difference between talking to a family that they've got a 1-year-old versus a 5, versus a 10, 15, and a 20-year-old. A lot of experiences would influence that as well, but time in terms of the family and how they've adjusted to something that was unexpected, potentially. And so how we use the F words is really different, but I think the common thread for me, when I reflect on what it is that I think is the commonality, function is, as broad of a term as that is the easiest way in, because it's doing something whilst understanding what this means for us as a family. Yeah. Do you know what I mean? I think
yes, and I do. And where I was coming from was that sort of professional understanding or interpretation of what function is, and I think still in 2026, despite the ICF being in place, the F words, etc., there's an underlying sometimes messaging, but interpretation that, for instance, and one thing I can reflect on is this concept of flexion is bad.
Okay.
Must fix flexion.
Yeah.
Must do everything because that's bad. And I think I talk about it in my course. It's such an ableist sort of view of flexion's bad to who?
Yeah.
And
that's
why?
Right.
And then you end up with, particularly in neurorehabilitation, where most of the kids and adults we see have a movement disorder. And they're always going to posture differently. That doesn't mean that we need to sort of cut nerves, cut muscles, do things to fix them. And that there's still an underlying, I think, even in some of the presentations that you see, some of that. And I think in Australia in 2026, when you hear about what happens essentially behind closed doors in many of these therapy centres, that's still the belief. Flexion's bad, must fix. Abnormal movements, all these things are bad. I mean, and so then it does that understanding what function is. It's not about how it's done. It's about whether or not the person can do it.
And that's the shift, isn't it? That's a really significant shift. So, Brian, how would you describe to a parent or a clinician about what function is from your perspective? How would you describe that?
Yeah, so that's actually a term a phrase that I use in terms of what my job is to support you in whatever goals that are meaningful to your child and your family. And it's not about how things are done. It's about whether or not your child can do it. And I'm here to try and, I don't know the answer. No one does. How is your child going to achieve the most optimal and efficient way of being able to do what they want to do? And that's the fun part of being a clinician. But that's, I think, and again, a lot of depth in this, but one thing is a clinician's view on their role and their confidence in their role. And a lot of families may come to a clinician expecting technology, lots of money, lots of these things and concrete interventions that we can do. Do they make a difference? And so then it's, I think, talking to families about sort of what works. So embedding very early, this is what these interventions are, but more than that, just what's in the inherent part and the consistent part of those things. So yes, I think the discussion needs to happen early is probably the most important thing, because families do go on all sorts of journeys, and we've all seen it.
Seeking information, seeking someone to listen to them and in a way meet a need. What happens, and I'm sure you've had these conversations before, we say, however the child might be able to do this, but we want them to be able to do what they need to function in daily life. It's not about how they do it necessarily. That's probably where I get the most pushback. It is kind of like, well, but I want them to, so in my area as physios, it's usually like, but I want them to go heel, toe, gait, and that's central focus, what it looks like. And that's where they're at. And so I often from there would go, okay, so it's heel, toe, gait. That usually means, I try to then explain the why behind it. But then what we need to do to walk, we actually want them to walk really efficiently. What does that actually mean? I try to sort of bring in the functioning in real life of what that means. And that takes a bit of time, though, because it does go back to that body structure and function conversation a lot with parents still. Do you encounter that too?
No, all the time. I've got some, again, golden moments that will almost always happen, especially in kids with unilateral cerebral palsy. An example is dressing, for instance. And so we have in our field, thankfully, this concept, thanks to Lena Krumpelman-Sundholm and Anki Eliasson, about functional hand use and hand roll differentiation. And that might sound this sort of big theoretical principle or principle, but when you break it down, it's really meaningful. And so when I had lots of experience early, for instance, when I was in the hospital and a family would come in and say, oh, Johnny can't pull up his pants. That's one of our goals. It's really important. When he goes to the loo, we want him to be able to pull down and pull up his pants. And then you'd say, as a good therapist should do, is maybe in a more discreet environment, but Johnny, show me how you would pull your pants down and pull them back up. And then with some families, what would happen is Johnny would go, okay, Johnny, and Johnny does very quickly, one-handed down, very quickly, one-handed up. Job done. You'd say, well, what's the problem? And that's, he's not using two hands. And so that's one of the prime examples I give to families around, who cares if Johnny doesn't use two hands? He's successful, he's effective, and he does it with minimal effort. And where time is wasted, which is my whole sort of philosophy, stop wasting family and kids' time, you can work on that for 10 years and Johnny still, as soon as he walks out of that practice environment, he's going to use one hand because it's efficient, effective, and done with minimal effort, which is this concept of functional hand use. And that for us as OTs is really difficult to get across. And if a family has been on this navigation or this sort of journey earlier where that's not embedded, it's really hard to sort of undo. But if we do it earlier, it's a part of understanding, and it's sort of this celebration of, again, the outcome rather than the method.
That's right. So within that context, and on the flip side, what I can also see would happen from there is he can do it with his dominant hand. Why would he engage in therapy for bimanual skills, for example? Like that other side of going, because sometimes I think you can look at the F words and go, they can do everything in their daily life. Where does therapy fit into that, and why would we engage with it?
So I mean, in our practice, I think, again, the F words have really framed, or the ICF initially, and the F words resonated with and sort of really backed up what we were doing. And we have this transition program where we really focus on these early skill development at the time they're most rapidly happening. So that to me, that's the function part. We're optimising. And the kids that we see will get to a point at which they are generally using the actions and skills that they've got really efficiently and effectively. Once you reach that point, it's usually getting ready for school. So support the transition and they go to school. And in our service, we don't see kids generally at school age very often. We don't need to because they should be doing what they want to do and need to do and having fun, making friends, hanging out on the weekend with their family, doing all those things. So we've implemented that model for a really long time and it really makes sense. But and it's fascinating because on the courses I teach, when I talk about this model, therapists will say, well, the families we see will be really concerned about that because we expect ongoing therapy. Not a single family in our service has any problems with that.
Of course.
They're delighted that they're not dragging their child or having a therapist go to wherever it might be to do that. And I think where that comes from is both the family sort of expectations, but also there are these things, as you know, Dana, that you would have been taught a lot throughout your career, is that if you stop doing it, there's these secondary catastrophic effects that are going to happen, particularly from a musculoskeletal. It doesn't happen because they're using what they've got.
That's right, that's right.
Yeah.
And I think it's continuing to challenge just because it's the way it's always been done doesn't necessarily mean it's the right way. And I think where the F words do help with this is we need to challenge the notion because therapy does have its place. It's important. It supports children to live their very best lives. It supports the families. But when and how, we've spoken about this extensively previously, when and how we do it is the question that fits in more of the F words, just a model that's just a weekly model or a fortnightly model. That's when I would ask, what is the point of doing therapy in that context, right? So it's the focus periods of time, transition points. There's a need then, and I think it's very needs-based rather than I guess us fitting in with the child rather than the child fitting us in with our scheduling. Yep.
Yeah, correct. And I think that what it comes down to is the lack of goal setting.
Yeah.
So if you don't have a goal, and this is where this suits the diary, suits the service, doesn't it? And the managers, we've got busy diaries for every fortnight or every week, ad infinitum. And what are the goals? And you would have experienced this as well. And I ask every time I see a family being somewhere else, what are the goals you've been? They can't tell me. Dare I say it? Sometimes I say, "Oh, well, we're not in the sessions. We don't know." It still happens.
That's right. That's right.
But I think Peter, that concept you were talking about, Peter Rosenbaum, sort of in his keynote at the start, a brilliant keynote to start the
wasn't it?
Conference, but his concept is avoid the tyranny of orthodoxy. And I think that's it's a nice way of saying exactly what you said, really. But Peter's got a way with
he does have
words.
a way with words, So
I think should be our mantra always. There are the things always question.
That's the part I want to hook on there. I think coming to a conference, one of the things you said at the beginning was I come here and I'll listen, I'll question. Questioning in our profession, no matter where we are in our career. I mean, I do this as part of my side hustle here in the podcast. I ask lots of questions. But we actually need to be asking questions all the time, even to work that's being presented.
Oh, absolutely.
Why? Yeah. Why should we be doing that? And talk me through that.
I mean, Peter said in his presentation, question what I'm saying in this presentation.
He did say that, didn't he? Don't just take my word for it.
Question everything we've all said on a podcast, for instance, because, and that's, I mean, I can reflect personally on what I was taught 26 years ago when I was a new graduate OT. Not a single nothing I was taught do I use in 2026. And the only reason that is because of me questioning where did that come from? And I'm a sort of special case perhaps where if I'm told something, I want to know where it comes from. So a fact or a figure, like there's this sort of usual thing of do 6 hours of stretching. Where does that come from? Well, it comes from a study of stretching soleus in a really poorly designed study. And that was
just like part of our practice.
Absolutely.
As soon as I graduated.
It's 6 hours.
6 hours, yeah.
So I think it's a fundamental skill that we should always question. What I would hear though is often when therapists on my courses would say, we don't have the time to stop and think. And I can sort of see that, but then isn't it, would you want to go to a doctor or someone who's so busy that they don't stop and think and challenge and question themselves?
Yeah, that's right.
So I think it's incumbent upon all of us to, absolutely.
And when it's personalised, you are stopping to think all the time, really, if you think about it. When something is personalised, you're not just applying a protocol with not thinking about the motivation for the person either, are you? So it's part of the process. Can you give me an example, Brian, of when you felt, like when you last made a tweak or, felt challenged by some research and you adjusted something that you did? I mean, you're an expert in the field, you're practicing, you're teaching.
I think probably like all good therapists, you pick up bits of information, especially at conferences or courses, and then you go and try it.
Yes.
And that's what I've done.
Yes.
And an example might be functional electrical stimulation, for instance. I often get asked on my courses, why don't you do it? Well, I'm a trainer. I've done the trainer course of FES, and I think it has a really important place in a particularly acute rehabilitation where you can start much earlier than and in a functional sort of purposeful way. And I tried it with kids with CP. And then I really started to question, well, no, they've got selective motor control. Why? Yeah. And by the time I've set up the electrodes and spent sort of half an hour trying to elicit this really probably faux purposeful functional activity, which didn't have a lot of meaning, I thought it doesn't really play a very big part in this group of kids. So it's not a tweak. Yeah. It's me experimenting, going, okay, I can see some possible underlying mechanism of action and theory behind that. I'll give it a go. Yeah. And with informed consent from the person that you obviously, and the understanding of why you're doing it, and also in a family who wants to try that.
Yeah, that's right.
Yeah, so it's a constant state of learning, and I think that's where there's a perception that, these people haven't actually really done all these other things before. Well, we have, and we've been around for a while, but I think it's understanding if there's a sound rationale for the mechanism of action, it's worthwhile talking to families about trialling some of these things. Yes. But if there's not, that's when the questions, if you can't find some research or a theory or a principle that underlies that, I think you've got to question why you would even try that in practice.
It's a good point. And I think the mechanism of action is a really important point as well, where you're not just taking something at face value. Like, just because it looks like it might do something, let's understand why it could possibly do something, And I think I'm the same. Like, I love FES. My PhD was in FES and it was in foot drop. It was mostly and children use it as an orthotic device. And it was good because it was something that they could wear. It made sense. They're walking all the time. It was a great way for them to clear their foot if they didn't want to use an AFO. Applying it to other parts of the body, really tricky, because the devices are not designed for pediatrics. Doesn't mean I don't like it. I haven't seen anything that can be functionally useful just yet. And so I don't use it nearly as much as I thought I would. So it's an interesting thing, right? You might really like a technique, but how do you actually apply it? Well, the practicalities of it, that's part of doing it in real life.
Yeah, absolutely. Yeah. And it's interesting. I remember those days, and again, been around for a while. I remember those days of the FES within the orthotics, and it doesn't seem to have really taken off in any way.
It's like with any technology, right? Yeah. It's actually really tricky. And, some kids will really like using it, but they're few and far between for it. And I think you've got to be much older to decide to use them too. So it's really, and I think that's the whole point. That might have been my PhD, but I'm okay to move on to different things too, and that's okay. That has it defined, and I think it's really important for people who are listening to understand that there is this whole process that we all go through. We might be so-called experts in the field, but it's only because we have tried, we've evaluated, we've talked, we've been challenged, and we keep moving forward. And I think that's the real status, isn't it? Really. Yeah. So final question for you, Brian. Like, I can talk to you for a very long time. I think every podcast we say exactly the same thing. But to wrap it up, if you could advise clinicians to implement more of the F words into their practice, into their thinking, what would your advice be, Brian?
I think, thinking about the learning and from the conference and the discussion we've just had, I think is, yes, function's important. But I think those other F words, the 5 others, are equally important, and they're the ones that are, I think, missed and not. And so I would say de-emphasise the function part. Yes. Again, the way to view that is probably set goals, task-focused, task-related goals, support the kids and the families in achieving that. And then those other things are far more. And I would also say that those other F words like fun, friends, family, they're probably, many of those, we don't need to be involved in that. That's not, no one needs to pay a therapist necessarily if you've got a good family unit that's really supportive and actually gets out and about and supports their child with the disability, then I don't think that, and that there's therefore that stepping back from a therapist's point of view. We don't really necessarily, perhaps that's the ingredient there, is to step back and give families the time back to be able to enjoy those things.
I love it.
Yeah.
Great advice, Brian, as per usual. Thank you so much for going on this wild podcast with me as I just asked you questions I've just wanted to ask you and talk about.
Yeah, appreciate it.
Thank you so much. To all of our listeners, hope you enjoyed that. Once again, I know you love it when Brian comes on the show, and I think it's because we get to talk about some really practical things about how we implement evidence into our practice. So I'll talk to you all again really soon. Hope you enjoyed it. Goodbye for now.
Thank you.